Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
All right, welcome back to another episode of Coffee with Coker. My name is Mark Reiboldt, I'm the host of the podcast, and today we're going to jump right into another topic, actually following up on a topic that we've talked about a good bit. It ties to physician compensation and strategies specifically around value-based reimbursement. So I have joining me today Justin Chamblee, who of course has been on the podcast before. He is an executive vice president here at Coker and oversees and leads our team that provides services around physician compensation strategy, valuation, et cetera. And so we're actually talking about it. We're kind of doing a follow-up to a presentation that Justin gave at the MGMA conference earlier this year, and it was worthy enough. We thought that it made sense to kind of follow up and talk about it a little bit more detail, or at least different components of the broader presentation. So that'll be interesting here as we dive in. Before we do that, as always, I like to just cover a couple of housekeeping items as far as, first of all, saying thank you to you guys for listening. And if you're interested in more content like this, you can find all the Coffee with Coker episodes, coffeewithcoker.com. There you can also review the rest of the thought leadership material that Coker releases. We have material going out regularly, and so I would encourage you guys to not only subscribe to the podcast, but sign up for that email subscription that gets all of our content in your inbox weekly. And there you'll find our podcast, as well as other content that we put out regularly. So with that, thank you guys again. And I want to jump right into the conversation with Justin. Justin, why don't we just start by talking about giving a little bit of a landscape review on the current state of value-based reimbursement. Where are we at in that progression?
Yeah, it's a great question, Mark. And it's a very timely conversation. I literally just got off the phone with a client talking about their current value-based strategy and what they're trying to do with their CIN and ACO. So it's something that we are dealing with clients each and every day. But if we step up a level, really, the U.S. is not killing it in terms of the quality of care. If you compare the United States to some other highly organized, evolved nations such as Australia, Canada, France, Germany, et cetera, the U.S. has the lowest life expectancy. They spend more on healthcare as a percentage of the economy, the highest overall chronic disease burden. Obesity is 2 times the rate of these other countries. And the U.S. has the highest number of hospitalizations from preventable causes and highest avoidable deaths. So clearly a lot of opportunity to improve healthcare in the United States. And as we know, the government plays a huge role in healthcare in the United States, with roughly 18% of United States citizens being covered by Medicare, another 18% being covered by Medicaid. So roughly 40% of the population having some kind of governmental insurance. And so the government has pursued a number of strategies to, in essence, change the quality dynamics that exist right now, both through payment reform as well as regulation of costs. And we could all debate as to how well they are doing with those programs, but just a few interesting stats. 2/3 of Medicare beneficiaries right now are covered by an ACO. Another 1/3, well, the other 1/3 are still in traditional fee-for-service. So if we think about what the government has done to push Medicare participants into value-based models, they have done well. We then can debate the efficacy of those actual government models that they have put into place. Just a few other stats that may be interesting to those that are listening. The Center for Medicare and Medicaid Innovation has been taking a lead role in driving the value-based strategies forward. They have to date pursued 50 plus payment models. There are 528,000 providers participating in these and 28 million patients that are affected. Relative to the performance of these models, 6 of the 50 plus have had their statistically significant savings. 4 of those models have met the criteria for national expansion. And the last thing I'll mention before we move the conversation along is if you think about other areas of the economy, you typically don't think of the government as being a driver of change, meaning they're not the innovators. But what we find in the value-based reimbursement realm is that is not the case, meaning they are the innovators. They are driving change and dragging commercial payers along with them. The CMMI classifies payment models into 4 different categories based on the amount of risk that is taken on. And right now, roughly 18% of traditional Medicare is true upside downside risk. Another, I'd say if you look at the overall payment arrangement, 90% has some level of upside opportunity or downside risk, meaning only 10% of traditional Medicare is true fee-for-service with no value-based incentives in play. And if we compare that to commercial payers, only 10% of the commercial payer population has true upside-downside risk, and 55% of the commercial payer population is still traditional fee-for-service. And so if we think about those stats, meaning Medicare 10% fee-for-service only with no upside-downside opportunities, commercial 55% of true fee-for-service with no downside upside opportunities, and then with true downside upside risk, Medicare being roughly double what exists in the commercial payer population, you can see that the government is truly being a catalyst for change.
Yeah, I have to think that a lot of people hearing that would be a little surprised by those statistics. I mean, because like you said, you don't typically think of government bureaucracy driving innovation and kind of market leading or market changing dynamics. So yeah, I guess that's somewhat encouraging, but it also kind of points out some room that we can make up on the non-Medicare side of things, non-governmental side of things. So are there any examples there? I mean, anything that is coming out of the commercial market or just kind of the non-CMS market in general?
Yeah, that's a great question. And I guess just to make one comment about your comment is when you look in depth at the Medicare reimbursement mix right now, roughly 50% is what they classify as category 2, which is fee-for-service with a link to quality and value. And so a lot of this is the MIPS program, which we could talk about more later, but one could argue that based on how the link to quality and value occurs, it may not necessarily make a material impact on the reimbursement that providers are experiencing unless you have truly exceptional quality or truly poor quality. Mm-hmm. But based on how the economics are dispersed, if you're sort of in the middle of the range, which, of course, if you think about a bell curve, the majority of folks would be, it's really not going to have that material of an impact. And so while the stats sound good or feel good with roughly 90% of Medicare being linked to quality and value in some manner, a good chunk of that just may not necessarily be overly effective.
Yeah, it's not pushing the needle that much. Yeah.
That's right. But if you do turn to the commercial market, there's a lot going on, especially in the value-based space. And I would say one of the key drivers of that is what is going on in the Medicare Advantage market. And there's been a number of players that have popped up that are looking to take advantage of that Medicare Advantage market, taking on risk relative to patient populations, and then pursuing that risk, organizing the providers to manage care wisely such that it drives a return. And so one could argue that's not necessarily the commercial space, that's still the governmental space because it's dealing with Medicare Advantage, yet it is what I'll call non-traditional providers getting into that space. When you truly think about the commercial market, meaning the Blues, United, Aetna, Cignas, et cetera, there is activity occurring, yet it is a little bit harder to parse out because it is very market specific, meaning we have data surrounding what is going on with Medicare because it is a governmental program, it's publicly available, and oftentimes it is covering a wide geography of providers. Whereas what the commercial payers are doing could be specific to the Boston market or the Indianapolis market. And so unless you have specific intel tied to what's going on there, it's hard to gauge what the commercial payers are doing. Yet, if you look at the available data, all of the payers are pursuing value-based reimbursement in some way. If you look at their websites, there is a large amount of space dedicated to their value-based initiatives. If you look at press releases, there are frequent press releases surrounding new partnerships or the creation of narrow networks, et cetera, that are pursuing value-based reimbursement. And our experience is how pervasive that is very market specific. In the Atlanta market, one could argue that it is still a heavy fee-for-service environment. If we go and work with our clients in Boston, one could argue that the incidence of value-based reimbursement has been much greater there. So depending on the market you're in and what is happening with payers or employers there is going to influence what the commercial payers are doing in those specific markets.
Yeah, I think that's a good point. I feel like you see new headlines every week or, frequently about these types of partnerships like you're talking about, and these press releases come out and things like that. Do you have any, or can you yet even get a read on whether or not these types of programs, even though they are a little bit more market specific, are they pushing that needle any more than the CMS-backed programs, or is it too hard to tell, or is it too market centered? I mean, specific markets, I guess.
I think it just due to the lack of public data available with some of these commercial programs, I think it is difficult to tell how effective they are being. I have to imagine some are and some aren't, no different than some of the governmental programs are as well. And so I think over time, what we will see is those programs that are most effective, we will hear more about, we will see them growing in popularity, being pushed further. Yet, what I think I can speak to is the continual experience I have is commercial payers are less willing to come to the table and renegotiate blanket increases in fee-for-service reimbursement. Typically, if there is a desired increase in reimbursement through contract negotiations, oftentimes that is being tied to value-based strategies, whether that is specific pay-for-performance programs or participation in CINs. More and more payers are using the ability to pursue value-based reimbursement as the means of pushing reimbursement up or creating the opportunity for increased reimbursement versus blanket increases in, let's say, the conversion factor that they're applying for fee-for-service dollars.
Which kind of tees up the next point. Since we are talking about how value-based reimbursement and value-based care affects provider compensation strategies and different models that are out there, let's talk about comp for a second. And I want to talk about some of the metrics, the surveys, and how that's evaluated here in a minute as well. But before you do that, talk about just maybe what are some of as it relates to value-based reimbursement, what are some of the key challenges that you're seeing when it comes to comp?
Yeah, that's a great question. And the challenges do abound. If there weren't challenges, we would have gotten this all figured out. And
Sure.
we, I think, would see a much more greater adoption of value-based reimbursement and even compensation arrangements tied towards value-based reimbursement. And one of the key dynamics that I think we have a struggle with right now is the fact that in many value-based reimbursement realms, or what we're asking physicians to do in that space, the investment of time, the investment of physician or advanced practice provider time, when coupled with the value-based reimbursement economic structure, does not equal market-based compensation. Meaning, we have physicians pursuing or participating in a CIN. The shared savings that may be coming through the CIN is not enough to appropriately compensate the physicians for what we're asking them to do in that CIN. And therefore, if we cannot demonstrate the ability to make market-based levels of compensation, I think it's always going to be difficult to get a physician to agree to participate. Mm-hmm. So I think that is just a overarching challenge that exists, is the lack of connectivity between the economic structure, the time investment versus the ability to drive market-based compensation. And until we fix that component, I think we will struggle with truly moving the needle forward with value-based reimbursement strategies. But outside of that, I think there are a number of struggles that largely surround getting a physician to truly accept this as a means of driving compensation. One of the key struggles that we see across the board is the access to data, meaning we have very robust electronic health record systems that are great at capturing the data, but they may not be great at disseminating or reporting the data such that we can use it to drive care forward. And if a physician cannot appreciate or understand the metric that they are being compensated on and the associated performance with that, they are going to be less receptive to their compensation being tied to such. Just highlighting one or two others, I think one is the perceived decrease in compensation, meaning if we have been in a largely fee-for-service reimbursement environment, we've compensated physicians based on work RVUs, let's say. Well, if we want to implement a value-based reimbursement element, it may not be that we can tag that on top of the existing fee-for-service compensation structure we've had to date. It may be that we have to rebalance the economics such that a portion of the compensation that the physician has received to date is now at risk tied to quality. That doesn't always go over well, meaning physicians feel like it is a takeaway versus something that is additive. And therefore, trying to get the provider to buy into that concept is difficult. If we try to articulate our movement in compensation structures are aligned with what we're seeing as movement in the reimbursement space, I think it helps a bit. But given a lot of this activity is dealing with employed physicians who have been shielded from some of the broader market reimbursement shifts, at least for the last number of years, it's hard to get that buy-in. And so I think helping a physician connect those dots does prove problematic and creates challenges as we move down this pathway.
Yeah, you mentioned the lack of data or the lack of quality data. And I want to kind of tie that back to taking a step back, I guess. You got to have, if you're going to go into a risk-based model, you got to have the quality of data and information that, allows you to be adequately compensated for whatever you're doing under that model. But I think if you even go further back in the process, even just establishing the compensation models and the different key inputs that determine how those models ultimately work and are calculated, you got to have various degrees of information, various types of information as we're doing our work for clients, different types of analysis, but we rely heavily on survey data. And I know a lot of people ask about survey data and they have their different takes and views on that and how meaningful it is, because it is critical in what we do as far as advising our clients on different compensation models. So I say all that because I'd like for you to comment. We've talked about survey data in the past, some of the key things. Talk about that for a second. Where are we right now with survey data? How is it influencing, what we do, what our clients ultimately decide, and, maybe even talk about kind of the future, where that's going?
Yeah, great question. And I'll speak specifically to it as relates to value-based reimbursement. And if we think about survey data has been used heavily to influence provider compensation, where those amounts are set, and the intersection between survey data and value-based compensation or value-based reimbursement is something that we spend a lot of time educating upon, both with physicians, but also health system administration. And as you think about some of the key surveys, Medical Group Management Association, American Medical Group Association, Sullivan Cotter and Associates, all of those surveys are putting out compensation data that represents total cash compensation. So as we think about let's say an employed physician who has a quality element in their compensation arrangement right now, by nature, that is part of their total cash compensation. It's going to be reflected on their W-2, and therefore it is going to hit survey data. Even a private practice physician that is participating in some type of value-based reimbursement arrangement that is ultimately in some manner going to flow down, hit their net income, which of course is compensation in a private practice environment. That net income is going to be reflected on a W-2 or a K-1, and therefore it's going to hit the survey data as well. And so from our vantage point, if you just think about how the survey data is compiled, it does include an element of quality incentives in the respondents. And even the surveys have gone as far as reporting or commenting on that. So MGMA in recent surveys has said 7 to 11% of total cash compensation is comprised of quality incentives. Sullivan Cotter, as relates to their surveys, have made similar comments. And so our interpretation of survey data is that if we're thinking about, let's just say, median compensation includes an element of quality incentives, and that needs to be factored in when we are establishing market-based compensation for a physician, both in terms of their base, their production incentives, as well as quality incentives. If we take that one step further, the total cash compensation per work RVU ratio that is reported in surveys that's used heavily is simply a calculation of each individual respondent's total cash compensation divided by their work RVUs. And so if the total cash compensation includes an element of quality, by nature, the total cash compensation per work RVU includes an element of quality. So once again, just using it as an example, if we're targeting median compensation per RVU, that median compensation rate per RVU should be assumed to have some element of quality in it. And so it may not necessarily make sense to pay median comp per RVU plus a quality incentive. It may make sense to pay a median rate per RVU inclusive of a quality incentive, and then having to decide how much of that we truly tie to pure production versus quality-based incentives. And I'm using the median here just as a simple illustration. I'm providing no commentary surrounding what may be market-based or fair market value, et cetera. Sure. It's always good to note that.
Absolutely, yeah. But it's an easy metric to at least speak to and conceptually. So if I think you said 7 to 11% from MGMA and Sullivan Cotter kind of similar, are we trying to extrapolate that from the total cash compensation, or are we doing kind of what you just said, where we're just assuming a percentage of that total cash compensation at whatever, the median or otherwise benchmark is just assumed that there's some value-based?
Yeah, I think as a foundation, we are just noting or assuming that quality incentives are baked into total cash compensation, and then how that is apportioned, meaning as we think about building compensation structures, how much we're putting in the production bucket versus the quality bucket versus other buckets is really specialty and organization specific based on the incidence of value-based reimbursement in their specific locale, their market, their internal dynamics. And so it's more so approaching those conversations knowing that the survey data includes an element of quality incentive, and then using our expertise to apply survey data as well as other data points appropriately in building their comp structures.
Instead of, like you said, just tacking it on top of,
That's right.
of basically an additional amount. So, okay, one of the things that I think is interesting here, trying to bring it full circle a little bit, is I guess when your comments looking back a little bit, and some of those statistics, it's encouraging that we've made some progress and we're doing something, but I guess we can all agree that there's still a long ways to go and plenty of gaps that need to be filled here. So I know one of the questions we get regularly from our clients and others that we, engage with out there in the marketplace, where do we start, or what more can we do? Maybe we have started. Like you said, maybe there is a portion of their compensation models that ties back to value-based reimbursement, but I guess if we're looking at some practical recommendations or practical steps that organizations can take, what would you say there?
We could spend hours talking about practical action steps. And so I'll try to distill it down into 3 things that we oftentimes communicate to organizations that we are working with in comp strategy initiatives. The first is think about external value-based reimbursement dollars that are coming in as a form of revenue versus pass-through compensation. What I mean by this is we saw a lot of organizations in the early days of P4P programs or value-based reimbursement seeing a $2,000 incentive coming in for Dr. Jones, and they say, hey, it's only $2,000, it's labeled for Dr. Jones, we're going to take that and just give it to Dr. Jones on top of any compensation structure we already have in place. What we have seen is that $2,000 swells to $3,000, $10,000, $20,000, and can be a pretty major form of reimbursement. And if you tie this back to a comment I made earlier, wherein increases in payer contracts are oftentimes layered into the P4P programs, that's what's causing these dollars to swell. So this is truly new forms of revenue that are coming in. And if we have set the foundation or the precedent that we are passing those dollars through to providers on top of a market-based compensation structure, it's in essence taking new forms of revenue and giving it to the physician. And of course, that could raise compliance questions, yet it also is not financially viable. And so what we really need to think about is those new forms of revenue as being truly revenue versus additional forms of compensation. And then we need to build a comprehensive compensation structure that complements where our revenue is coming from. So that's the first item is truly understanding what our revenue sources are, what they mean, and treating them appropriately. And the second item is a corollary to that, and that is making sure that we have a comprehensive compensation structure that is aligned with where we are going from a value-based reimbursement realm. I use the extreme example. If we are 100% fee for service, and likely will be that way in the future, it does not make sense to have a capitated compensation structure. Similarly, if we are moving down the pathway of capitation, it doesn't make sense to have a pure production-based or volume-based compensation structure. So we need to make sure that we are moving in lockstep with changes in our reimbursement structure so that we're not too far ahead or too far behind, but we are making sure that incentives stay aligned within our compensation structure based on what is driving reimbursement. And I would say building compensation constructs that add and provide some level of flexibility so that you can adapt them over time is key. The last thing I will mention, and this is largely geared towards primary care, is starting to think in the context of panel and panel incentives. And I would encourage organizations to start, if they are not already, at least measuring panel, calculating it, talking about how to define panel in their organization, because just starting to have those conversations is helpful. It can be a new measure of productivity, but it also can be used as a means of measuring production and compensating on production going forward. And so within primary care, one of the things that we're seeing more is providing a happy balance between volume-based incentives and panel-based incentives, meaning having a work RVU element and a panel element, because it starts to recognize and reward the primary care physicians for all of the work that they do to support patients that is not direct patient care. It also helps us prime the pump for the potential for more capitation in the future, which is helpful. And so just to recap, those are three things that I would pursue or think about as practical action steps. And that is rethinking how we talk and think about and treat reimbursement. Number two, making sure that we have a compensation structure that is aligned and moving in lockstep with changes in our reimbursement structure. And then the third, really focused on primary care, is thinking about and starting to institute some level of panel incentive into our compensation constructs.
Well, that's helpful, particularly as far as key action items and considerations and just either getting started or maybe taking these programs to the next level. In some cases, organizations may need to kind of right-size some of this stuff as well. What about, as we kind of think about closing out here, any final takeaways as far as where to start, how to really get their mindset and going in this direction of some of those things some of those recommendations you just made?
Yeah, great question. And what I would encourage each organization to do, whether it is a private practice, a hospital employed physician network, a private equity-based physician network, is truly step back and build a comprehensive strategy as to what you are doing in the value-based realm. That is both in terms of what sources of new revenue you are pursuing, what the financial impact of that is, are you ability to make money in pursuing those, what's the risk associated with it, how do we align incentives with those new revenue streams, but truly building a comprehensive business plan, getting clinical leads involved, looking at all of the associated considerations, and then moving forward in that manner. What we see a lot of organizations do is, because of all the talk in the market tied to value-based reimbursement, there is this perception that we need to be doing something, and therefore we see a lot of activity, but it's really not tied to any true strategic plan. And at the end of the day, what we see is it is more noise and distraction for organizations to deal with, and that leads to frustration with physicians because of the time that they have to invest. And ultimately, there's really not a return for anybody, providers, both in terms of physicians and health systems, as well as patients in terms of the impact of quality of care, et cetera. And so I think stepping back, having a comprehensive strategy, and then executing on that is the key. So don't necessarily just go change your comp structure to include a value-based element. Develop a comprehensive strategy as to where you're pursuing value-based reimbursement, and then make sure that your comp strategy aligns with what you're doing from an overall business plan.
Well, that comprehensive strategy, I guess, also helps eliminate or maybe reduce some of those potential hurdles that you talked about earlier, getting physician buy-in, the risk, getting them willing to absorb some risk, the data even, things like that, and the reporting and how that's used. So, yeah, I think that makes a lot of sense. And, we really skimmed over at a very high level, a lot of very detailed information here. Obviously, I'm sure there are a lot of questions that folks have, different organizations, challenges they're working with or working through. So as always, I like to encourage folks, if anything kind of jumped out here that you'd like to know more about or you have questions around, Justin and our team is always available. So you can reach out to us. We'll make sure contact info is available with the notes to this episode. But yeah, no, this is definitely something that obviously we're going to be talking about a lot. Clearly, we do a lot of work around physician compensation. And as value-based reimbursement continues to become more prevalent to varying degrees, as we talked about, it's going to be something that we continue to talk about and deal with and ultimately figure out as this system evolves. So, Justin, thanks for spending a few minutes talking about this. And I know we're going to talk about it more in the future. So we'll look forward to answering any questions and continuing to tackle this going forward. Thank you.
Great. Thank you.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.